Hello dear students. In this series of 25 important questions, today's subject is orthopedics. So starting with the very first question, which says that there is a young male who had road traffic accident and the clinical picture was given and we were supposed to make the clinical diagnosis. Now firstly what we will do, we will draw a line from the middle of the body, and then we will see the respective positions of both the lower limb, and we can see that both the lower limbs are abducted, right? So both the lower limbs are abducted. Secondly, what we can observe, that the lateral border of the foot is almost touching the couch, and this suggests some degree of external rotation. So there is external rotation bilaterally. And third, we can also see that there is flexion at both the hips. So the deformity on both the sides is flexion, abduction, and external rotation, which is suggestive of anterior hip dislocation. So this is anterior hip dislocation. Obviously bilateral in the given case. So this is anterior hip dislocation. Next question, again a patient with road traffic accident and is now as presented to the emergency. The X-ray is shown below. So the very first thing which we will do here, we will again draw a line from the middle of the body, and then we will see, we can just see that one of the lower limb is adducted. So this is adducted, right? What else we can note here? On other side, lesser trochanter is very prominent. So this is lesser trochanter. But on the injured side, the lesser trochanter is hardly visible. So it suggests that there is some internal rotation. So adduction, internal rotation. And thirdly, what we can see here, this is the outline of acetabulum, and see the position of head of femur. So it is dislocated. So obviously this is a case of dislocation of hip, and there must be some element of flexion also which is visible clinically. So this comes out to be a case of posterior hip dislocation. So this is classically posterior hip dislocation, right? So this is how we will identify posterior hip dislocation on an X-ray. Now next question, all of the following nerves can be injured in cases of fracture of humerus. So it means they are related to some part of humerus, and if there is any fracture of the humerus, they will be injured, and we have to find out which one does not fit. So radial nerve, this is injured if there is fracture of shaft of humerus. Ulnar nerve is injured if there is fracture of medial condyle of humerus, and axillary nerve can get injured if there is fracture of surgical neck of humerus. So we can see these are the nerves which can be injured if there is injury to the given part of the humerus, and nowhere the posterior interosseous nerve is related to humerus. So the answer is posterior interosseous nerve. So if we look in this image, we can see the axillary nerve related to the surgical neck of humerus, then radial nerve related to the shaft of humerus, especially through the spiral groove, and the ulnar nerve, which is related to the medial condyle. So these are the nerves which are commonly injured in different areas of humeral fracture. Now next question, a 3-year-old child had a history of fall from height, and at that time there was no abnormality on X-ray, but after 2 years the child developed the deformity as shown in the image. So what we can see here, there is a calcaneovalgus deformity. So this is calcaneovalgus deformity. Now in cases of children's, there might be possibility of epiphyseal injury which may be missed on x-ray, on initial x-rays, but later on the child, as he grows up, he might come up with some deformity. So in the given case it is calcaneovalgus deformity. So what might have happened, that the lateral part of the lower tibial epiphysis must have been injured, whereas the medial part will continue to grow normally. So what will happen? Progressively there will be a calcaneovalgus deformity. So this is a missed epiphyseal injury related to the lower tibia, especially affecting the lateral part of the epiphysis or the growth plate of the lower tibia, right? So this is how there is possibility that kids may present with some deformity later on, and initial x-rays might be normal because epiphyseal injuries are not that easily diagnosed on x-rays. Now next question, an obese woman presented with pain in both the knee joints, and then she can also hear some click sounds while walking, and the pain tends to be more while she's going upstairs or coming downstairs. An x-ray shown. What is the diagnosis? Now if you look properly, what we can see here, this is say the lower end of femur, and this is the upper end of tibia. So what we can see, there is reduction in the knee joint space, that is very obvious. That is one point here. Then secondly, if you just try to look at the position of the lower limb, it looks like there is genu varum. Of course, both the findings bilaterally. And this is classical of osteoarthritis of knee joint, obviously bilateral in the given case. So the pain will tend to come when the patient goes upstairs or downstairs, and there will be some sounds, clicking sounds whenever the joint is moved, and classically seen in obese patients. So this is classical description for osteoarthritis of knee joint. The next question, uh, an elderly patient underwent THR. So this is total hip replacement done for osteoarthritis of hip, but after 5 days he developed breathlessness. So what can be the cause here? Now in long duration surgeries like THR or TKR, and in elderly patients, there is high possibility of deep venous thrombosis, and related to this there might be development of pulmonary thromboembolism. So this is a classical presentation of pulmonary thromboembolism, which is consequent to the development of DVT, which is classically seen in long duration surgeries in elderlies or with prolonged bed rest. So this presents classically with respiratory symptoms like dyspnea, tachypnea. Clear? So this is DVT leading to pulmonary thromboembolism. Next question. A young male who used to take non-veg diet had the following presentation, and here we can see there is redness, swelling in the first metatarsophalangeal joint or in the great toe. So redness, swelling, or you can say features of inflammation affecting the great toe or the first metatarsophalangeal joint. So the moment you have this kind of presentation, it is usually gout, and this is supported by the diet of the patient, and the uric acid levels are also on the higher side, and then the patient is having similar episodes in the past as well. So it is a case of chronic gout. And in chronic gout, we give one drug, that is allopurinol, which acts by inhibiting xanthine oxidase, right? So this is the enzyme which might be inhibited by the drug which is given for chronic gout, that is allopurinol. So this is xanthine oxidase.